Unicondylar knee arthroplasty. UKR is better than T&O in over 60 years of age. Advantages of unicondylar knee replacement over total knee replacement. It's retain the cruciate ligaments, preserve the knee kinematics. Number 2, faster rehab, better range of motion, short hospital stay, less blood loss, less expensive, easier to revise, reduce complications, better patient satisfaction. Disadvantages: higher revision rate than total knee replacement. Revision rate is nearly 4 times higher than a primary total knee replacement. Risk is 15-20% in 15 years. Indication unicompartmental osteoarthritis. Types: mobile bearing, reduces contact stresses, or fixed bearing for lateral side due to increased excursion of lateral compartment during knee movements. PA view in 45-degree flexion Rosenberg view for medial unicondylar knee replacement, and 30-degree Schuss view for lateral UKR. Technique: incision on the medial border of patella, extending distally, avoid excessive releases. Under correction, the mechanical access to some 2 to 4 degrees, as complete correction or over correction can lead to loading the other compartment. Excessive caution to avoid ACL or tibial spine injury. Optimal mediolateral placement of the tibial tray and avoid impingement of ACL. ACL deficiency is a contraindication for UKA but not T&O. Contraindication: inflammatory arthritis. Number 2, fixed varus or severe varus more than 15 degrees. Valgus. Flexion contracture of more than 15 degrees. Previous meniscectomy. BMI of more than 35. Knee flexion less than 9 degrees. Ligamentous laxity or instability, bicompartment osteoarthritis. AVN has worse result but not a contraindication, or coronal knee subluxation more than 1 centimeter, whereas thrust with incompetent MCL. Complications: it's still a extensive surgery. Loosening is possible, dislocation is possible, stress fracture is possible, disease progression is possible.